Hello, everyone. Type in the chat if you can hear me and if you can see my screen. Hello. Wow. Okay, the chat's going crazy. Hello. Hi, everyone. Type in the chat where you're tuning in. Well, hello. Can you all hear me now? Oh my God, I think there was too much in the chat that my computer just completely froze. Right. So, sorry, can you guys hear me, see me? Is there any lag? Okay, awesome. Perfect. So sorry, where is everyone tuning in from? Awesome. Wow. So we have people from all over the world. And next question is what year is everyone in? Like, are you guys applying for medical school next year, or what grade are you guys in? Wow, awesome. Okay. So we got a variety. I can't actually see the chat very well, but awesome. So today's session is going to be basically about what life's like as a surgeon, and we're going to do some cases together, and then we're going to learn a few how operations are done. We're going to learn about anatomy and some physiology, and then in the end we'll have some Q and A's. And I think the best way to do question and answers, because the chat is a bit it's a bit crazy. I don't think I'll be able to see your questions. So if you type the Q&A, the questions into the Q&A section of the Zoom, then I can see them at the end. Okay, but you can use the chat to talk amongst each other if you guys want, but I wouldn't be able to monitor the chat because it goes quite quick. Is that okay? And yeah, don't worry, your audio and video is off, so don't worry, you're not on camera. Okay, awesome. So let's jump right in. So next slide. So this is me. My name is Osama. I'm a doctor. I graduated from Imperial College London, and I was training to be a radiologist, and then I switched to work in the pharma industry, and I've been doing that for 5 years now. And yeah, I love medical school. It was one of the best times of my life, and I hope you guys get to experience that because it's awesome. Okay, so we're going to use Menti today. So to log into the Menti, you can use a QR code here because there's going to be questions on there, or you can use the code as well. So let me paste the code into the chat so you guys can see it. And yeah, so if you guys log into Menti, I'll give you guys a few minutes. Also, I think you can upvote each other's questions on the Q&A. So if you see a question that you really want answered, then then please please upvote that. Is there still lag at the moment? Can you guys hear me well? I might need to switch my internet. Okay, chat is saying I'm lagging. Okay, one sec. Let me just switch my internet and then I'll be right back. That should be good. Audio is fine with me. Okay, let's carry on, and then we can see if there's loads of lag, then just let me know. Okay, come on. So let's jump in. So the first case of today is a 33-year-old patient who presents with generalized abdominal pain. She also reports that she hasn't eaten all day, but despite this, she still feels sick. The pain has been progressively getting worse, and now the pain is sharpest in the right lower side of her tummy. Okay, and by the way, guys, like in these sessions, I don't expect you guys to know any of this, so don't worry if at this stage you're not sure what's going on. And some of the concepts we'll cover are a bit tricky, so don't worry if at this stage you're like, "Oh my God, what's going on? I don't know." Don't worry, okay? Because we will go through it, and you're not expected to know this at your stage. Certainly, when I was at your stage, I had no idea what was going on. Okay, so first question is, what would you like? Would you like to find out further information about this patient? What do you guys think? Yes, well done. So you're right. So we should. That's good. Those nine of you voted sounds normal. I'll send the patient home. That's not good. You don't want to send this kind of patient home. So let's have a look. So what questions would you guys like to ask this patient? So now you got the patient in front of you. What kind of questions would you like to ask them? Wow. So there's a lot of questions. Very good. Let's keep them going. Yeah, the Zoom session is recorded, by the way, so don't worry. It'll be accessible later. Um, okay, how do I mute the chat? Is the chat quite distracting? Because I think I can mute it, but I don't know if you guys want that. Doing like a democratic vote. Let's see. Mute chat. If you want to mute the chat, let me know. Type yes. Type W in the chat. Let's have a look. Okay, I think the W's have won. So how do I mute this chat? Chat preview. I actually don't know how to mute this chat. I don't think it's possible. Oh, I know what it is. Here we go. It's here. Oh, the chat is now muted. So if I'm lagging, can you please post in the Q&A that I'm lagging so that I know? Or raise your hand. If I'm lagging loads, then just raise your hand so then I know that we're lagging. Okay, cool, awesome. Okay, perfect. So let's keep going. So there's some very good questions there in the chat about this patient. So what we want to do is whenever a patient comes in with pain, we want to remember the word Socrates because Socrates helps us structure how we ask about pain. So what Socrates stands for is the S stands for site. So where is the pain? O is for onset. So when did the pain begin? C is character, so is it sharp, dull, achy? R is for radiation. Does the pain go anywhere? A is for associated symptoms like nausea or vomiting. T is for timing, so when did the pain begin? And then exacerbating, E is for exacerbating or relieving factors. Anything make the pain better and worse? And then severity. How bad is the pain? Now, this helps us really find out quite a lot of questions about the pain in a lot of detail, and that helps us categorize the pain. So, for example, if a patient comes in with left-sided chest pain, which started 10 minutes ago, it's very sharp. It radiates to the left neck and the left shoulder. It's associated with shortness of breath. And the timing is on all the time. Nothing can seem to make it better, and exercise makes it worse. And it's 10 out of 10 pain. What do you guys think the patient has? Like one, I'll give you guys a chance to type in the chat. Go, type. What do you guys think it is? Left-sided chest pain. What do you guys suspicious of? Excellent. Well done. Heart attack. Very well done, chat. Smashed it. So very good. Well done. So this is why Socrates is very useful to be able to know a lot about the pain and to be able to characterize it. Okay. And then further to this, you can also ask the patient about other things as well. You know, like part of the history is to ask the patient their family history, their medical history. Are they on any medication? Also, have they had any operations before? You can also ask about their travel history, their social history, like what they do for work and things like that. So that forms part of your history. So history basically means you're taking information from the patient and trying to decipher that to find out a diagnosis, which is what you want to do. And then from that, you can then offer a treatment. Okay, so now let's quickly cover anatomy. So anatomy is a study of where body organs are in the body. So in this session, we're looking at the abdomen, basically, which is the area of the body underneath the diaphragm, which is a muscle that separates your chest from your abdomen. And I'll show you guys in a second. But in general, what we do with the abdomen is we divide it into 4 quadrants. And that helps us find out which quadrant is affected. So in whichever quadrant is the pain, you could then deduce what's going on in that part of the body. So then you can nail down what might be going on. Okay, so I'm going to stop sharing the screen. I'm going to share a different screen and we're going to talk through some anatomy now. So let me show you guys something. So let's have a look at this. 1 second, I'm loading this. Share screen. Okay, you now should be able to see an anatomy model. Can you guys see that? Type in the chat if you can see the anatomy model. It's wiggling around right now. Okay, awesome. W's in the chat, come on. So let's have a look at the human body. So this is a human body, okay? It's a very fascinating system, and you basically divide it into different parts of the body. So this area we're looking at now is called the abdomen. Let me show you guys some other parts. So if I add respiratory and muscle, so the area above this muscle here, this is called your diaphragm. It's a dome-shaped muscle that separates your abdomen, which is this area here, with your chest, which is this area here. Okay, your chest contains your lungs and your heart, and it's a major part of your body, and that's why it's very well protected by your rib cage. And you have the sternum here at the front, and then in the back you have your spine here. So it's a very well protected part of your body because your chest contains your lungs and your heart, the 2 most vital organs. I mean, every organ is vital, but these 2 are very important. Okay, so that's your chest, and then underneath it we have the abdomen. Okay, so anything underneath the diaphragm is your abdomen. Many people think that your rib cage actually ends in your chest and there's no rib cage covering the abdomen. And that's actually not true. You can see the rib cage actually goes down and it actually protects the liver as well, and also your spleen here and your stomach. So your rib cage actually protects the upper abdomen as well. Okay. Um, so today we're going to look more closely at the abdomen area. Okay, so let's have a closer look at that. So let me remove the chest, and I'm going to remove the diaphragm as well. So now this area of the body is called the abdomen. Okay, let me also add urogenital and endocrine. So the abdomen is mainly composed, there's loads of organs there, but mainly it's your digestive system that's there. And most of the function of the abdomen is to support the digestive system. So the digestive system is actually one very long tube that runs from your mouth all the way down to your rectum. And it's a tube that's around 7 meters long. And it's all curved around like this. Okay, so it starts off right at the top. Here you have your mouth. And your mouth is then connected to something called your food pipe, which is your esophagus. This is your esophagus here. The esophagus sits right behind a major tube that's important for breathing, this tube here. Anyone know what the name of this tube here is called? It sits in front of your esophagus. Yeah, your trachea. Excellent. Well done. Your larynx actually is your voice box. It's just above your trachea, but well done. This is called your trachea. Excellent. Okay. And remember, your trachea sits just in front of your esophagus. Okay. So the esophagus goes all the way down. It goes past the diaphragm, and then it becomes your stomach. Let me remove the rib cage as well, actually, so you guys can see it. So that then it becomes your stomach. You guys see the esophagus becomes your stomach. Okay, it's all connected. And then your stomach is kind of like an enlarged tube where mainly what happens is your stomach has a lot of stomach acid and it's mainly used for digesting proteins. And then your stomach then continues to become what we call the small intestine. Okay, so it's all one long tube. The first part of the small intestine is called the duodenum. Okay, you can see it here. This is duodenum, and it goes, and then the duodenum then becomes something called the jejunum, and then that becomes the ileum here. So all of this is called the intestine. So there's three parts of the small intestine: the duodenum, the first bit, the jejunum, and then the ileum. Okay, and then this becomes the intestine. So you can see here, and this first part is called the cecum. The cecum goes up. This is called the ascending colon, transverse colon, descending colon, and then sigmoid colon. Okay, you don't need to worry about the names, but it's just the idea of this, and then it becomes a rectum here. And don't forget, there is this very small tube that comes off the cecum. It's a blind-ended pouch. Anyone know what this small tube is called here? Can you guys see this small tube here coming out? What is this tube here? Type in the chat. Appendix. Excellent. Well done. That's correct. So it's called the appendix. Oh gosh, I think there's lag. Okay, 1 second. Let me change my internet. 1 second. Okay, we're back, chat. Come on. So let's have a look. I think we should be good now. Let me share my screen. Right, let's have a look. Is everything good now? Can you guys hear me? Okay, come on. W's. Perfect. Okay, so let's go back to where we were discussing. So we got to this tube here. Anyone remember what this tube was called here, coming off your cecum? Appendix. Excellent. Well done. So that's called the appendix. Let me go back to meeting. Excellent. Um, so then your digestive system is basically one long tube, as I described. And what's very fascinating, by the way, is that when you're developing, so when you're a fetus, did you guys know that when you're in your mother's womb, the way this system is developed is that your digestive system actually comes outside of your body. It starts off as one straight tube, and then it goes outside of your body. It then curls around and then goes back into your body, okay, while you're in the uterus. And it's actually a very complicated process. And actually, sometimes some babies are born with their intestines outside of their body, and they have to have an emergency operation, well, an operation to try and fix that. I can show you guys maybe later in the session, but it might be quite a graphic condition to show you guys if you guys want to see it. If you do, then type in the chat that you'd like to see it. Okay, awesome. I'll show you guys after this case. Cool. So let's now talk about the other organs that are in the abdomen. So this is the digestive system, but there's other organs that help or assist with digestion. So one of them is this organ here. This organ here is the second largest organ in your body. Does anyone know what organ this is here? If you guys see my pointer? Yeah, excellent. This is called your liver. And then closely to your liver, you have this organ here, which stores bile. Anyone know what this organ is called here? Gallbladder, excellent. And then the other organ that we need to be wary of is this feather-shaped organ here, which produces enzymes and also produces hormones. The pancreas, excellent. So this one here is called the pancreas, excellent. Um, and then we also have other organs that are not related to digestion, but are also there. So which organ is this here? Anyone know? Kidney, excellent. By the way, when I ask you guys what organ, it's helpful to be more specific. So this is one of the kidneys, but which kidney is this one? Can you guys figure out which kidney this is? Bearing in mind, this is the liver, and you're looking at it from behind. So which kidney is this? Yeah, excellent. This is actually the left kidney, okay? Because the liver sits on the right-hand side, remember? So therefore, this is the right kidney, and this is the left kidney. Does that make sense? Okay, next question. The kidneys have this cute little cap here that also produces hormones. Anyone know what this is called here? Which gland is this? Adrenal gland, excellent. And which adrenal gland is it? Left or right? Left adrenal gland, excellent. Well done. Excellent. You guys are very good. Well done. Okay, one last question, trick question before I mute the chat. What is this here? This yellow stuff here. What is this? Yeah, excellent. This is visceral fat. The technical term is omentum. Excellent. Well done. Cool. Okay, actually, one last question before we mute the chat. What gender is this patient that we're looking at here, based on what you're seeing? Female, excellent. You can see the uterus here. You can see the ovaries. So this is the uterus, ovaries, cervix here. Okay, perfect. So this is a female. Cool, excellent. Let me mute the chat now, and then we can go back to the case. Cool. Let me reshare my screen. Okay, can you guys see my screen now? I guess you can't type in the chat, but I assume you can. Let me check chat. Can you guys see my screen now? Perfect. Excellent. Okay, so whenever we're looking at a patient that comes in with abdominal pain, what we want to do is find out where the pain is, because then it helps us find out which organ is affected. So, for example, if the patient comes in with right upper quadrant pain, then you know it's going to be related to either the liver, the gallbladder, maybe the transverse colon or ascending colon. Okay, if it's on the left-hand side, then maybe you're suspecting the stomach or the spleen, or for example, the pancreas. Whereas if it's more lower down, then you're suspecting more the appendix, for example, the cecum, the large bowel, or the rectum, that kind of area. Okay, so this is why it's helpful to know. And we've done this. So once we're there, we've now done a history from the patient. We've also found out a little bit more about the pain, but now it's time to order some investigations to try and figure out what's going on. So what investigations usually helps us? What do you guys know of that could help us figure out what's going on with the patient? Excellent. So you guys have mentioned so many investigations, which is very well done. So the thing is with modern medicine, by the way, and especially when you guys finish medical school, there's going to be mm, thousands and thousands of different investigations you can do. And already there are. But it's your job as a doctor is to find out which ones are relevant because you could order everything and then loads of things will come back and some of it might be irrelevant to what you need to know. Okay, so one of the major tests that we need to do at this stage is definitely do a pregnancy test. So this is what it looks like, a pregnancy test, because then you can decide what further investigations you can do. Because, for example, you don't really want to be doing a CT scan on a patient who's pregnant necessarily, because CT scan is X-rays, and you don't really want a pregnant lady to be exposed to X-rays. Anyone know why? Why? Type in the chat. Why do we not want or it's not recommended? Yeah, there's a risk of radiation, and then that could impact the fetus. Okay, it also can impact the mother. But that's not to say, by the way, that we don't do CT scan on pregnant people, because sometimes in an emergency setting you might have to do a CT scan. Like if someone was in a major traffic accident, then you might need to do a CT scan to find out there's an area of bleeding, for example, to save the mother's life and to save the fetus's life. So sometimes you might have to do the scan anyway, because to be honest, the risk of radiation is actually very small, especially these days with our new technology, new scanners. We don't actually use that much radiation. So you might actually need to do a scan sometimes in some cases, okay, some exceptions. But in general, the way we structure the way we investigate is, first of all, we start off with the basics. So on the bedside, you start off by measuring the heart rate, blood pressure, respiratory rate, oxygen saturation, temperature. These can all be done by the bedside. In fact, as soon as you enter the emergency department, usually these things are measured, usually. Okay. And then the next bit is then we can order some scans. We can take some blood and then look at some certain things. For example, look at the hemoglobin count. We can look at the white blood cell count. If a patient comes in with a high white blood cell count, what could that be a sign of? Type in the chat if someone comes in with high white blood cell count. Yes, excellent. So it could be a sign of infection. Okay, excellent. Well done. Very well done. Okay, and then if someone comes in with a low hemoglobin, what could that mean? And especially if it's dropping. Someone comes in with low hemoglobin and it's dropping. So anemia, good, but what are you thinking? If it keeps going down, someone hemoglobin keeps dropping, what are you thinking of? You're thinking of internal bleeding, blood loss. Excellent. Well done. You guys are so good. Well done. Okay, so let me mute the chat. So good. So you order these different tests, the blood tests, and then after that, then you can order other tests. Like for example, you can test the urine, you can test the cerebrospinal fluid, you can test the pleural aspirate, the stuff around the lungs, and then you can also order some imaging, like ultrasound, X-ray, CT scan, MRI scan. Okay, there's different types of imaging, and different ones are used for different causes. Okay. Generally, for abdominal pain, the most useful scan is called a CT scan, which is basically a 3D X-ray scan to look at the different organs. So, in fact, let me show you guys a CT scan, um, and we'll talk through it. Okay, so this is our patient CT scan. Okay, let me know if you can see it. Can you guys see the scan right now? I'm scrolling through it. Okay, perfect. You guys can see it. If I scroll through, you guys can see it changing. Excellent. So let's talk through the scan together and then we'll try and diagnose the patient. Okay, so this is our scan. So if you don't mind right now, I'm actually going to keep the chat open because I'm going to ask you guys questions in the chat. So if we can try and reduce the level of spam, that'll be awesome. But don't worry if you can't stop spamming, it's fine. Okay, so let me annotate. So at the top here, we're looking at the top of the patient here, where the CT scan, the way it's done is that it's a 3D X-ray, and you're looking at the patient as if you're looking from the feet upwards. Okay, so this side on the CT scan is always the right-hand side. Okay, remember this side is the right-hand side, this side is the left-hand side. Okay, so now let's try and label some organs together. Okay, so first organ I want you guys to identify is which organ is this here? Which organ is this here? Sitting between the two lungs, because the lungs, the way X-rays work is that you basically shine X-ray energy through the human body, and then different organs will absorb the X-ray energy differently. Okay, so the lungs, because they contain loads of air, they don't absorb any of the X-ray energy, and therefore they just look dark. Whereas bone is very dense and it absorbs most of the X-ray energy. Okay, and therefore bone looks white, very dense. Okay, so good. This organ here is the heart. Okay, now next organ to identify, which organ is this here? Which organ is this? Be specific. Okay, if I like lung is good, but the perfect answer is right lung. Very good. Well done. So this is the right lung. And then which organ is this here? By the way, notice which one is bigger. Which one is bigger, left or right? So this is the left lung. Good. Right lung is bigger. Good. Well done. Okay, perfect. Now, next organ to identify, or next bone to identify, what bone is this? Yeah, this is part of your spine. What is one part of your spine called? The whole thing is called your spinal column, but what is the one part called? A vertebrae. Excellent. And this vertebrae particularly is called a thoracic vertebrae because is in your thorax. Good. And now one last one in this section. What is this here? What bone is that connecting to your vertebrae? That's one of your ribs. Excellent. Well done. If you want to be more specific, which rib is it? Right rib. Yeah, good. Well done. Excellent. Good. And then also notice there's muscles here. These are your back muscles, the paraspinal muscles. Here you have your lats, for example. And at the front, you'll see, if I go down, you'll start to see the ab muscles come in. Okay, now, as I scroll down, now we're starting to see the abdomen. Okay, so this now is a cross-section of your abdomen. Okay. And in your abdomen, we now start to see the upper abdominal organs. Okay, so the first organ I want you guys to identify is this organ here. Which organ is sitting on the right-hand side? And it's the second largest organ in your body. So this is your liver. Excellent. Very well done. That's your liver. And then let's have a look more. I want you guys to identify this organ here. Now, this organ here, actually, this looks quite tricky, okay? But this organ here is actually your esophagus becomes this organ. So what organ is this? That's your stomach. Excellent. So I know it's quite tricky to see that's your stomach. And then here, this organ we haven't talked about yet, this here, this organ is called your spleen. Okay, we haven't actually talked about this organ here yet, but this is your spleen. Okay. By the way, don't worry if you find this very confusing, because it's actually very difficult to like understand this, because it's 3D conceptual. Okay, so don't worry if at this stage you're like, what the hell's going on? So don't worry. Okay. But I think you guys are doing very well. So if I keep scrolling down, then we start to see other organs appear. So now we start to see this organ here. This is a feather-shaped organ, which has got all the enzymes and hormones, insulin. Yeah, pancreas. Excellent. That's your pancreas here. Very good. And then also you start to see loops of small intestine. These are all the loops of small intestine, which could get quite confusing. And then as I keep scrolling down, now two organs start to appear. One of them is this one here, and the other is this one. What organ is this here? Kidney. Excellent. This is the right kidney. Very well done. And then this one here is the left kidney. Excellent. Very good. And then as I keep scrolling down, we can also see, by the way, that here we have the gallbladder. This is right next to the liver, called the gallbladder. Okay. And as I keep going down, we start to see loops of small intestine and large intestine. And then as I keep going down, we now start to see the pelvic region. So this here, these bones here are part of your pelvis. This bone here is called your femur. So actually, this session is 2 hours long, if that's okay. We have 2 hours, yeah. So it ends. Do you guys want it to end early? We can finish early if you guys would like that. But yeah, so in this patient, what we're seeing now is, I want you guys to focus. Remember, the pain was in the right-hand side, okay? The right lower region, okay? So this patient has, I'm going to point you guys to where the problem is, and then I want you guys to decipher what's going on, okay? So the problem is, if you look, this is a cecum here. So don't worry. If you guys can't see this, and don't worry, because it's quite tricky, but this is a cecum here. And from the cecum, you can see there's a tube coming out, and it's like a long tube, and it's actually very angry and inflamed. This is a tube here, it's coming out. And the reason why you can tell it's angry and inflamed is because, remember I told you guys that the organs in the abdomen are surrounded by fat. So healthy fat should look like, you see this dark stuff here, this kind of black, almost black, dark. This is what fat should look like. But in this patient, you can see that around the tube, you can see the fat around the tube is swelled up and is gray. Can you guys see? Can you guys see there's like a difference between the color here and the color here? And this is how you interpret CT scans. It's about differences in color, okay? So what's going on here is that the fat around this structure here is got is basically inflamed and it's got loads of pussy, white blood cells, all that kind of stuff. Because when the body knows there's something inflamed, it sends white blood cells there. So what organ is this here that's been enlarged? Anyone know what tube? What tube comes off the cecum? Excellent. So this is the appendix. And when the appendix is inflamed, what do we call that? Appendicitis. Excellent. Very well done. So this patient has appendicitis. Now, as a doctor, you should also pick up on other clues as well. So there is actually a clue in this scan why this patient is unlikely to be pregnant. Can anyone tell me why this patient is unlikely to be pregnant? I want you to look at this region here to see why this patient is unlikely to become pregnant. Yes, excellent. So this here, can you guys see this very white, bright white structure here? This is what we call an intrauterine device. It's a form of contraception. By the way, whenever you see anything really bright on a CT scan, always think, could it be something from outside of the body? Because very rarely are things that bright. Okay, even bone is like quite bright, but it's not as bright as this. Okay, so we've done this on purpose so we can see it. So this is called an intrauterine device. It stops you from, it's got a very high chance of stopping pregnancy. But that doesn't mean to say that you can't get pregnant, but it's a very strong form of contraception. Cool. Okay. So this is why this patient is unlikely to be pregnant. Okay. So now what do we do next? We've identified the patient has appendicitis. What's the next step? What do we do? Okay, don't worry, I'll mute the chat in a second, but what do we do once we've identified? Okay, so now we need to think about doing an operation. Okay, perfect. So now let's talk through the operation. So let me just share a different screen and then we can look at this operation. Right, give me a second. Right. So now let's see how I can share this. So share, advanced. Right. Can you guys see the screen yet? When you can see it, let me know. Okay, if this works, then it's going to be massive W. Come on. I think it's about to work. Oh my God. Has it worked? Come on. Smashed it. Awesome. Okay, guys. So we're now in the operating room and we're now having a look at how to do a laparoscopic, which is a keyhole operation, to remove the appendix. Okay, so first of all, we need to prepare the patient. So the patient is anesthetized. Okay, let me mute the chat for now. Well, thank you, Jude. I'm very proud of myself. Thank you. So I've muted the chat now, but I'll reopen it in a second. But now what we're doing is we need to prepare the patient. So the patient is anesthetized. So they're gone to sleep and we need to clean the area and drape the patient. So we only really uncover the part of the operation that we need And we put drapes everywhere else because this is to stop um, infections, basically. We want to be very clear. And then we start the operation by making an incision just below the belly button. And this first incision is where we want to put our camera port. Okay, so we carefully dissect down, very carefully, making sure that we don't cause any damage to the structures. So we're opening up the rectus here. And then the surgeon will then use their finger to make sure the area is clear to insert the probe. So now we insert the first probe. And what we do is then we inflate the abdomen with air. Therefore, we can have a clearer view. And then we put in the first port, which is a camera port. Okay. And then we lean the patient back so that we have a clearer view of the intestines, which we'll see in a second. And then we make another port. And then we usually have another port as well. So we usually have 3 different ports. And now we have a view of the patient's intestines. So here we can see the patient's intestines. And what we're doing is here now we're trying to locate the appendix. So this is all done through keyholes. This is the camera. We're looking at the camera view and we're trying to locate the appendix. And we found it. So this here is the appendix. This is the cecum here. Can you guys see in this patient, the appendix is inflamed. It's really big. Usually it should be a very thin tube and it shouldn't be angry and inflamed. But in this patient, it's inflamed because they've got appendicitis. And you can see there's an area of this mesoappendix, which is the connective tissue around it, is also quite inflamed and tortuous. So what we want to do now is we want to start carefully dissecting the appendix. So just waiting for it to load. And we're dissecting now the appendix very slowly. And we're using cautery to stop any areas of bleeding. And very carefully, we're cutting the connective tissue around the appendix. And then we're using this suture to try and cut off the appendix now. So here we go, we're cutting it off. And then we can carefully dissect down. These loop sutures are very helpful because you can quickly place them. And we're carefully cutting off so that we mitigate the risk of bleeding. We don't want too much bleeding. So now we can cut the appendix off now completely. And you can see the white stuff coming off. That's pus. That's white blood cells. So this appendix is quite inflamed. And now we put the appendix into a basket. And then we can then take it out of the body. Now we need to make sure there's no bleeding left. So we use saline to try and irrigate the area. Everything looks quite clean. There's no signs of any bleeding. So this operation was successful. And now we can take out the appendix. We can take out the different instruments now. We'll finish the operation. Make sure the ports are clean. we can deflate the abdomen now, take out the ports, and then we take out the umbilical cord and we can then suture everything up. And then that brings us to the end of the operation. So let me unmute the chat, see if there's any. So was that okay? Did you guys see that? So this is what we call laparoscopic operation. And this is done, can be done very quickly, actually. Within 20 minutes, you can have the appendix out. Isn't that cool? So this is, in the future, almost most operations will be done like this. So when you guys are training, you'll probably be doing operations like that, which I'm sure you guys will be amazing at doing that. So let's have a look in the chat. Any comments? Let's have a look. Wow, cool. Yeah, it's actually amazing. So let's go back to our patient. So we've done this, we've done the appendix. So this is the reason why we're doing operations because it's necessary. We don't generally do operations where they're not necessary, okay? So what are the risks of doing an operation? Because every operation carries a risk, okay? So in general, the risks are that there's always a risk of wound infection because you're opening the body up. You're always introducing maybe bacteria, things like that. You have to be very careful. That's why the operation is done very, very meticulously to try and avoid that. Also, there's a risk of bleeding because just in case, for example, you've seen how tight the human body is. If you accidentally ping a blood vessel, that could become a source of bleeding. There's also the risk of anesthesia. So some patients, they don't react well to anesthesia. I don't know if you've guys seen on TikTok, for example, on YouTube, some patients, when they wake up from anesthesia, they're a bit delirious. They don't know what's going on. Or some people are allergic to it as well. So you have to be very careful of that. And then there's also, after operation, there's going to be pain. And some patients are better dealing with pain than others. And also there's a risk of blood clots. Okay. And then specific risks with every operation, there's a specific risk. So, for example, in this case, you might accidentally damage the cecum. You don't want to do that. You want to be very careful not to damage that. Okay. And then there are advantages of doing keyhole operations. So this kind of operation is called a laparoscopic operation. And the reason why we want to do a keyhole operation is because there's less pain, there's less risk of infection, a shorter hospital stay, and a faster return to normal activities. Okay, sure. For now, I'll quickly mute the chat, and then we can come back to the chat in a second. So yeah, this is why we do a keyhole operation, okay? And this patient had what we call appendicitis, which is inflammation of the appendix. It's not really clear what causes appendicitis, but in many cases, it's caused by something that blocks the entrance of the appendix or bacteria. And most often, it occurs in patients between the ages of 10 and 30. And typically, the patients start with a non-specific abdominal pain, which then localizes to the right lower quadrant. Okay, so that's appendicitis. Perfect. So we've now done the first case, and it's been, I think, about an hour. So do you guys want to take a short break and then we can go into case two? So maybe if we take a 5-minute breather. In fact, are you guys happy to carry on, or should we just do a break, a quick break? What are you guys saying? Type in the chat. Type break if you want a 5-minute break. We'll carry on. Okay, come on. Let's carry on. People are saying carry on. Let's carry on. Cool. So case number two. You can also, by the way, like you're not on camera and you're not on audio, so you can go grab yourself a drink or something if you want. You go to the bathroom as well. So you are a doctor working in the emergency department in this scenario, and the patient, which is a 40-year-old patient, comes in with severe abdominal pain. Okay, so with this patient, in what order do you want to do these things? So let's have a look. What would you guys do? Remember the patient came in with severe pain. So what do you guys want to do? Okay, good. So, um, almost there. So remember the patient is in severe pain. So I think before taking a history, it would be advisable to give the patient some form of pain relief because you don't want to be speaking to a patient who's in severe pain. It's not very kind. So the first step would probably be to give the patient some analgesia, which is pain relief. And then you can take a history, and then you can order a CT scan if you want. Then you can send the patient to operating theater. Okay, so the kindest thing to do is first of all give the patient some pain relief, and then we can take it from there. So then, what question would you like to ask about this patient's pain? Now, remember what we covered earlier. What would help us in this case? Like how best would be to ask about the patient? Oh, is this working even? Let's have a look. There's no, oh, responding is off. 1 second. Let me turn that on. Is that on now? That was an amateur error. Oh my God. There's so many responses. Cool. Awesome. So many questions. So good. You guys are taking the Socrates approach. Very good. Excellent. So remember Socrates is site, onset, character, radiation, associated symptoms, timing, exacerbating symptom, and severity. So good. Well done. You guys asked all of that. So well done. So remember, this is what Socrates is. So this is what we find out. So JD is a 54-year-old female patient who presents with sharp right upper quadrant pain. She's been experiencing abdominal pain, bloating, and indigestion for several weeks, and the pain is usually after eating specifically fried chips. She also noticed that her urine has become darker in color. Today, the pain was excruciating, and she decided to present to the emergency department. She's got a past medical history or surgical history of hypertension. Does anyone know what hypertension is? Type in the chat. Hypertension. Well done. So it's what we call high blood pressure. Good. What is hypercholesterolemia? Anyone know what hypercholesterolemia is? High cholesterol. Excellent. Well done. And then she's had two previous C-sections. So what are C-sections? Anyone know what C-sections are? What kind of operation is that? So that's a cesarean section, which is for pregnancy. Good. Excellent. And then in terms of drugs, the patient is on ramipril once a day. Anyone know what ramipril is for? Everyone, so well done. Someone said it's an ACE inhibitor. Very well done. So yes, it's an ACE inhibitor and it's used for blood pressure. So it's to lower blood pressure. And then she's also NKDA. Anyone know what NKDA is? What's NKDA? So NKDA means no known drug allergy. So remember, whenever you ask a patient about any medication, also ask them about any allergies as well. Okay. So well done. And then we asked about family history. There's no family history. And she works as a dinner lady at school. She's a non-smoker and she drinks alcohol occasionally. So first question was, what is ramipril? So we kind of covered that, but let's have a look. So it's a blood pressure medication. Well done. You guys are good. Next one. What do we do next with this patient? Excellent. So we want to admit and investigate further. So remember, what we want to do is we want to escalate up the ladder. So we start with observations, then we do maybe order a blood test and other tests, and we might do some imaging. So generally, we do history taking, observations, physical examinations as well. So we can feel the patient's abdomen. We then the further test, and then we either decide she needs specialist care or we can then discharge home. And remember the anatomy. So remember the different sections. So Our Lady has right upper quadrant pain. So which organs are there? And then we can deduce what's going on. Okay, so then we order a CT scan, and the pros and cons of each investigation is specific. So, for example, for CT scan, what's really good is that it's fast, it's relatively safe, it's well established, it's flexible, and it's good for looking at different organs. The cons of doing a CT scan is that there's a risk of radiation. So a CT scan is very useful in some cases. This is our patient CT scan. In fact, let me show you guys the proper scan, and then we can go through it together. So this is a scan. This is different to the one on your Menti, but this is a better scan to look at. So what we're looking at here is we're looking, in fact, let me open the chat again so we can talk about the organs. So I want you to look at this area here. This is a upper quadrant. If I go down, this is the liver. We now start to see this organ here. What organ is this next to the liver? What organ is this here? Gallbladder, excellent. This is a gallbladder. And what do you guys notice is inside the gallbladder? What can you guys see? Can you guys see anything inside the gallbladder? So bile is this. This is what bile looks like. But what can we see here? They look kind of like pebbles, no? So these are what we call gallstones, okay? See, this is the gallbladder here, and you can see gallstones. So this patient has what we call gallstones. Okay, and this is actually another illustration of it. This, can you guys see? This is the gallbladder here. This patient's gallbladder is very inflamed. And what is this here? Gallstone, yeah. So you can get gallstones. You can get kidney stones as well. You can get stones in other places in your body. You can even get tonsil stones, like in your mouth, and they're very, very foul smelling. So well done. So you're right. This is the area of concern here. You can see there's in the gallbladder, there's a stone there. So what do we find on this CT scan is that we can see there's a gallstone. The gallbladder is very big and distended, and this means basically means it's inflamed. And also around the gallbladder, there is some collection of fluid. Okay, you guys won't be able to appreciate this, but it looks very inflamed. Okay, Mitti's asking what causes inflammation. So inflammation is caused when an organ is basically upset. So then the body will send blood there, redirect blood supply. Will send white blood cells there. Will send inflammatory markers there to try and tackle. Inflammation is a way for your body protecting you, but it ends up being bad for you. If that makes sense. It's like it's a process that happens when an organ isn't happy. And what exactly are stones? So stones are they're made of like literally like calcium and different minerals. Okay. So remember, this is what we call the biliary tree. In fact, it's better if I show you guys on the anatomy app. So let's have a look at that. So let's go back to this. Can you guys see the anatomy app? Let's have a look at the chat. Excellent. Okay, so this is what we can see. We can see, I want to isolate the liver, so let's have a look how we can do that. In fact, if I I'll remove this. I'm going to remove the stomach, and that way we can have a clearer picture. I'll remove the duodenum as well. So here we go. So if I zoom in here, what you guys will see is this is the liver here, and this is the gallbladder. Okay, and what happens is your gallbladder basically stores bile. So this area here, this is called the common bile duct, which then moves bile to for it to be secreted in the duodenum, which is a small intestine. Okay, let me try and make it clearer. So here, can you guys see that? In fact, it's quite tricky to depict this. Let me see if there's a better way. 1 second. Give me a second. I'll share a different screen so that we can see it better. Hmm. So I don't know if there's a better model. I think maybe the diagram will show it. Okay, so let me share the diagram. 1 second. To be fair, this diagram might actually be our best bet. So this diagram is showing the liver here, and then the liver basically produces bile, and then bile goes down and then gets stored in the gallbladder. Okay, and bile is used to emulsify fat, so it's very useful. But depending on your diet and depending on different lifestyle factors, that bile can then crystallize and turn into stones, and then you have gallstones. And then sometimes gallstones are small enough to just be secreted into the digestive system and then they go away. But sometimes they become so big, and then anytime the gallbladder contracts, it causes very severe pain because the gallbladder contracts against a gallstone, and it's literally like a rock, so it causes pain. So that is not ideal. You don't want that. And generally, the gallbladder contracts when you're eating fatty food, because remember the role of the gallbladder is to emulsify fats. So that's why the patient will experience generally pain after eating fatty food or when they're digesting that, because then gallbladder contracts against the stone and it causes pain. So the duct here is called the cystic duct, and then this is called the common bile duct, and it goes into the duodenum. Cool. So what is the function of the gallbladder? So the gallbladder's main function is to store bile. It also concentrates bile to make it stronger. It also alters the pH of bile because remember, the food coming out your stomach is going to be acidic, so you want to neutralize that. So bile is used to neutralize that, and the gallbladder also helps maintain the pressure in the biliary system. So the gallbladder is actually very important. And what happens is if you have gallstones, then that could cause a condition called cholecystitis, which is the inflammation of the gallbladder. So anything to do with the gallbladder is called chole. For example, cholecystectomy is when you remove the gallbladder. So cholecystitis is when the gallbladder is inflamed. Okay. And this is what happens in acute cholecystitis. And sometimes, if it gets really bad, then the gallbladder could inflame so much and then actually puncture. So it's like a balloon that dilates up and then puncture completely. And then you get really bad, all this stuff leaking out into your gut. And it's really bad, very bad for the patient. You can go into sepsis and things like that. So what do we do next? Do you guys think we should send the patient home, observe the patient for a few hours, or send the patient to the operating room? Excellent. So you guys picked right. So we want to basically do an operation in this case. Perfect. So now we're going to have a look at a different operation. So what we want to do is we want to give the patient some antibiotics as well to help settle the inflammation. And then generally with this kind of patient is that depending on how much the inflammation is on the CT scan, we either take the patient to the operating room or we give the patient some antibiotics and then wait for 1 or 2 days so the inflammation settles, and then we go for an operation. The reason being is because if you operate on someone on a gallbladder that's very inflamed, you don't run the risk of breaking it, and then you end up with all that nasty stuff into the abdominal cavity. So you don't want that. So sometimes we wait until the inflammation settled slightly, and then we can do the operation. And generally, we do a keyhole operation. So now let's try and have a look at that operation again. So let's see if this is going to work. If this works, then we have another W, comma. Can you guys see the screen now? It might be lagging slightly. Oh my God, it's lagged on my home screen. Okay, perfect. So can you guys see that? It should be the operation. Perfect. Okay, so again, we start the operation with the patient anesthetized and the patient draped. And then we want to make an incision under the umbilicus where we put in our first port. So we dissect carefully. And now we're putting in the first port. I know it's lagging. I'm sorry. Oh, should I mute? Maybe if I mute, it'll stop the lag. Let me mute for a sec. Cool. Okay. So then what we want to do is we want to inflate the abdomen. Sorry, the animation is lagging, but hopefully my voice isn't. And then what we want to do then is reposition the patient. And now we can see from the camera, we can see the abdomen. We can see all the fat, the visceral fat surrounding the organs. We want to now locate the second port, and then we put in a third port as well, and then we are going to identify the gallbladder. So we can see the gallbladder here. This is the liver here. This is a gallbladder. So we want to carefully take away the gallbladder. You can see it's quite inflamed, and you want to deal with it very carefully because remember the gallbladder is inflamed, so it's very malleable at this stage. If you accidentally nip it too hard, then you might actually break it. So you don't want to do that. You want to be very careful. We dissect very carefully the connective tissue around the gallbladder, and we want to also identify the blood vessels so that we can cauterize them. So here we're dissecting very, very carefully around the liver edge, taking off the gallbladder here. Okay, just waiting for it to load. I'll wait for it to load. Oh God. Start again. So let me go through this quickly. Fast forward. We'll go here, confirm. We've already done this bit. Let's fast forward a little bit more. Here we're dissecting. Here, we're here, confirm. So we're dissecting the artery here now. We have to be very careful. We put clips there to stop any bleeding, and then we can then cut the artery. Can you guys see we're putting clips there? These clips will stay in the patient's body, by the way. So whenever you do a further scan, you'll be able to see the clips on the scan. Okay, so it's very laggy, but I hope the voice is okay. Can you guys hear my voice okay? Hopefully it's just the app that's lagging, not my voice. Perfect. So we've done that now. So then we can cut the artery. See, we're cutting the artery now, and there's no bleeding, so that's really good. And then we cut the cystic duct as well, and there's no bleeding. Excellent. That's perfect. And now we can continue dissecting the gallbladder. Gosh, this app is so lagging. But it's working. Okay, perfect. Now we're dissecting more of the gall. You can see there's little elements of bleeding, but we're trying to stop any bleeding. So we cauterize any vessels that look like they're bleeding. Look, there's a little bit of bleeding, but it's doing well. And the stick thing that's cauterizing is called dithemy. It uses heat, like basically a short circuit current that basically stops bleeding. And now we've finished dissecting the gallbladder, so mission successful. We can now retrieve the gallbladder. Again, we put it into a basket and we send it off to check the specimen. So we can take this out now. Mission successful. And no, we don't replace the gallbladder. It's gone forever. So good question by Rushi is that what happens if there's any internal bleeding in the first place? Can you insert the cameras? How do you control the bleeding then? So if it's really bad bleeding, then you might actually have to open up the abdomen. Oh, so it stopped sharing now. So anyway, that was the end of the operation. So we can stop sharing that. So yeah, that was a laparoscopic operation. Another one that we saw. Okay, so this is yeah, the gallbladder's gone forever, and what the patient does now is that when the liver produces bile, it just goes straight into the digestive system. That you don't store the bile anymore, which causes some problems. So the patient is told after the operation to not eat as much fatty food. They have to regulate the diet better, because then won't be able to digest fatty food just as well as if they had a gallbladder. Does that make sense? Perfect. I'm really sorry about the lag. I don't know why I don't know why it's happening. I think because there's so many people in the chat, it's quite crazy. So I'm sorry about that. And this is what a gallbladder looks like. So gallbladder that's inflamed has got a thick wall and it's got all these stones inside, and these are actual stones. Okay, like literally, if you feel them, they're rock solid. And actually, some patients after the operation they keep this. They want to keep it as a souvenir. Um, there are some cases where you can just go and remove the stone, but if it's already too far gone, then you have to remove the whole gallbladder. And by the way, it's quite normal to find like as you get older, it might be normal to have one gallstone, but it's just if it causes infection and pain, then that's when you need more. You need to remove it. So what are the risks again? So again, there's risks to every operation. So there's wound infection, bleeding, risk of anesthesia, pain, and blood clots. And then again, the risk here is damage to organs nearby. And then the advantage of doing a keyhole operation is there's less pain, less risk of infection, and shorter hospital stay. So now let's do some questions together. So which of the following is not a risk factor for gallstones? So a risk factor means that you are increased chance of developing gallstones. Anyone know which one do you guys think? I mean, we haven't really covered this, but what do you guys think? So actually, the one that isn't a risk factor is a low-fat diet. So actually, gallstones are more common in females, but males still get them. Also quite common, but it's just more common in females. It's more common in obesity, and more common if you have already had a family history. But yeah, it's a low-fat diet that is less common. So sometimes you don't know why, but it could be due to the different hormones between males and females. Like for example, estrogen could be one of the factors. But it's just some diseases are just more common in different people, if that makes sense. What is a primary function of the gallbladder? What do you guys think? Excellent. So it's to store bile. The bile is produced in the liver. Glucagon is produced by the pancreas, not by the gallbladder. And to regulate blood glucose levels, that's also the pancreas as well, insulin. So it's not to do with the gallbladder. Good. Next question. So which treatment option is typically recommended for symptomatic gallstones? Surgery to remove the gallbladder. Good. Well done. Which of the following is a complication of untreated gallstones? So this one you have to deduce. So do you guys think you guys know what hypertension is now? So it's high blood pressure. Coronary artery disease is to do with the heart. Osteoporosis to do with the bones. So which one do you guys think is a complication of untreated gallstones? Excellent. So it's cholecystitis, which is inflammation of the gallbladder. Excellent. Well done. And then which of the following procedures is used to remove the gallbladder? So is it laparoscopic cholecystectomy, an MRI, endoscopic ultrasound, or ERCP? So these kind of questions, you want to do it by deduction. Remember, anything to do with chole is um, to do with the gallbladder. So excellent. So laparoscopic cholecystectomy. Very well done. Good. Now this we haven't covered, but again, by way of deduction, metformin is used for diabetes. Atorvastatin is a statin which is used to lower cholesterol. Ibuprofen is a pain medication, also for anti-inflammation. So well done. So the correct answer is urosadiol is the one used to dissolve gallstones. We can give that to some patients. And now I want you guys to look at this scan. This is what we call an ultrasound scan. Do you guys think there's gallstones here or not? And this is showing the gallbladder here. So remember, we can do different types of scans. This one's called an ultrasound scan. It's slightly different to a CT scan. So what do you guys think? Is there gallstones here or not? Excellent. So yes, you can see the two little pebbles. Those are what we call gallstones. Now we can show a different type of scan now. This is a CT scan. So what do you guys think? Can you guys see any gallstones here? Remember where you have to look on the right-hand side. Can you guys see any gallstones here? What do you guys think? Excellent. So yes, you're right. There's gallstones there. Now let's have a look at further scan. Now this scan, you can see a CT scan again. You can see the liver here. You can see the gallbladder here. Can you guys see any stones here? Remember that sometimes you do a scan and it might not show anything. So what do you guys think with this scan? Can you guys see anything? Is there any signs of any gallstones? The answer is no. Excellent. You guys are so good. Well done. That was excellent. Well done. And now this is the last kind of scan we'll see. This is called an MRI scan. So you can see a different detail here, but the liver looks slightly different on an MRI scan. And then we can see this is a gallbladder here. And the MRI has different colors. Okay, so there's different shades of gray, but can you guys see that inside the gallbladder? Can you guys see these dark areas? What are they? So this is an MRI scan. So yes, well done. So this, you can see there's gallstones here. Well done. You guys, very good. Excellent work. Let's have a look at the leadership board for now. Excellent. We have Pingu as number one. Beyonce is in the chat. Well done. Beyonce 2, number 3, and Simba as number 2. Well done. Who's Pingu, by the way? Type in the chat if you're Pingu. Okay, so now we have half an hour. We don't have long. So let's do one last case, and then we can go to Q&As for a little bit. In fact, we probably need to rush this case so I can get to Q&A. So case number 3 is a 25-year-old patient who's involved in a road traffic accident. He walked himself to the emergency department, sat down in the waiting room, and for the past hour, he's been experiencing worsening headache and reduced alertness. So what system of the body do you think is affected in this case? What organ system are we looking at? Excellent. So what the organ that's affected is called the nervous system. Excellent. So what we worry about here is the brain. So neurology red flag. So what are things that we need to watch out for? So if someone comes in with a severe headache, multiple episodes of vomiting, confusion, drowsiness, change in balance, weakness, or paresthesia, which means altered sensation, then those are red flag symptoms we need to investigate further. And how do we examine the nervous system? So the way we do that is, first of all, we test the patient's alertness level. So we do this by doing something called the Glasgow Coma Scale. This tests 3 different things: the eye opening, a verbal response, and motor response. And it's graded out of 15, and the lowest you can get is 3. Okay? So let's have a look now at what a normal CT head looks like, and then I'll show you guys a scan of our patient. So this is what a normal CT head looks like. This is a 3D X-ray scan. We're looking at the brain here. So this is the right-hand side again. This is the left-hand side. And you can see that what you're looking for essentially is symmetry. So the brain should be quite symmetrical, that you shouldn't see any obvious areas of asymmetry. And you can see the different lobes of the brain. So let me quickly talk you through, guys, through the lobes of the brain. So the brain is split into two hemispheres. You have the right-hand side and the left-hand side. Remember, the right-hand side of your brain controls the left side of your body, and it's the other way around as well. So the left side of your brain controls the right side of your body. And there's different parts of your brain that have different purposes. So for example, your language sensation, if you're right-handed, the area where you process language is generally on your left-hand side, comprehension and things. Okay, so it's very variable from patient to patient, but every patient has a right hemisphere and a left hemisphere. And each hemisphere can further be divided into 4 different lobes. So you have the frontal lobe here, which mainly to do with personality and executive decision making. Then behind that, we have the parietal lobe. And then as I scroll down, you have the occipital lobe at the back and also the temporal lobe. Okay, these are different lobes of the brain. And other parts of your brain that you need to be wary of is here, this area here is called your brain stem, which is very important because this area of the brain, the reason why it's right in the middle is because your brain stem controls your existence, basically. It controls your response level, it controls your reflexes, it controls your breathing, your heart rate, everything. So this area here is vital. If this area here gets affected, then you can die from this. Okay, so this is very, very needs to be very well protected. So this is what a normal CT scan looks like. In fact, I'm going to show you also what an MRI scan looks like, because MRI scan is more detailed. Can you guys see MRI? This is what MRI of the head looks like. Can you guys see the level of detail here compared to the CT scan? But generally, we want to do a CT scan because CT scan is very quick. You can do one in 5 minutes and get a result, but an MRI scan takes much longer. So if someone comes in with an emergency, you generally don't want to do an MRI scan, you do a CT scan. Okay, so this is what an MRI scan looks like. This is if you want more detail, and you can see a lot of detail here. You can see the eyes. Can you guys see the orbit? See the lens. You can see the muscles that control the eyes. This is the brain stem here. You can see the blood vessels that supply the brain. These are the blood vessels. If you look, what's good about these kind of 3D scans is that you can look from the side as well. You can orientate them. So now we can see the areas of the brain very clearly. You can see here, you have the frontal lobe, parietal lobe, occipital lobe, the brainstem here. The brainstem continues to become the spinal cord. You have here your very primitive part of your brain. This area here is called your hindbrain or the cerebellum. This is the cerebellum, okay? You can also see the tongue here. You can see, so this is what an MRI scan looks like. It's very detailed, okay? This is what I'm trying to show you guys. And this is what a normal MRI scan looks like, okay? So a normal MRI looks like this because everything is symmetrical. So just notice that, okay? So now going to our patient, this is their scan. So what do you guys think? Which side, type in the chat, which side is the problem? Right-hand side or left-hand side? Where's the problem? Right-hand side, excellent. So we have a problem on the right-hand side, and we have a bright area here, which is pushing on the brain and is causing the brain to lack symmetry. You can see there's what we call midline shift. So you can see the midline is shifted to this side. So you can see it's going like that. And we have an area here, which is very bright. So what is this bright area? What is it? What do you guys think is going on here? What is this? Let's lock in and solve it. What do you guys think? It's bleeding. Good. It's blood. Excellent. Now we want to find out what's the reason of blood. So we can have a look at a different angle of the CT scan, a different shade. And now there's an answer. Why is there bleeding in this patient's? Dr. Sama's tripping, someone said in the chat. Am I tripping? Come on, let's solve this case. So we have a fracture here. Well done. So you can see there's a cracked area of bone. This is a fracture. Now remember, um, it's normal to have suture lines on your skull because your skull is different bones that fuse together. So for example, here, can you guys see this line here? This line here? That's not a fracture. That's a suture line. That's normal because these are two bones that fuse together. Whereas here, can you see there's a fracture? It's a break. It's a big break. Does that make sense? So this patient has basically fractured their skull, and that's caused bleeding. And therefore, this patient has intracranial hemorrhage. So hemorrhage inside the brain. And this is very bad news because if the bleeding continues, then there's going to be more compression on the vital structures of the brain. And then you can even get death from that because if you compress on the brainstem, then that can compress your breathing and everything like that, and you can die from that. So this patient, what do they need? Anyone know what they need? What do we need to do with this patient? How do we solve this? Surgery, excellent. So we need to do an operation. So I'm going to show you guys an operation now, brain operation. Now this is a real operation. So are you guys okay with it's going to be quite gruesome? There's going to be a lot of drilling and stuff like that. Are you guys okay seeing this? Type in the chat if you're okay. Okay, come on. Let's share it. Okay, so I'm going to stop sharing this. I'm going to show you guys the operation. Okay, hang on. I'm just trying to locate it. Okay, let's see. I think it should be coming up soon. In fact, it hasn't loaded yet. Let's have a look. Oh no, I think this video got removed. Let's see. Oh no, what a shame. This video, maybe it was too gruesome. It got removed. Let me try. I'll just find another one. 1 second. Give me a second. Okay, hopefully this should work. Sorry, guys. Now is a good time to take your break while I try and find this operation. Um, Gosh, so let's find it on this. Hang tight, everyone. I think I've almost found it. Oh, I'm actually quite gutted. I think they just banned this whole video. Okay, so it's too gruesome to show you guys. So it's been banned. So let me show you guys an alternative. So let me share my screen. Have a look at this. Don't worry, we got this. Come on. I know some of you might have lost faith in me, but hopefully this should do the trick. Right, come on. So here we go. We're starting now a craniotomy procedure. So a lot of this operation is about positioning. So we want to accurately position the patient so that we can get to the area of the brain where the bleeding is. Okay. And what we're going to do basically is remove a part of the skull to try and relieve the pressure and stop the bleeding. Okay. So first of all, we need to position the head in a right manner, and then we're going to shave the scalp. We don't want any source of infection there, folliculitis, anything like that. We clean the area. We swab everywhere. And okay, I'm going to mute the chat for now, and then we can, while we focus on this operation. So we are going to now demarcate the area where we want to make the incision, and then we drape the patient. So we focus a lot on cleanliness. This has to be really clean. And now we're injecting some local anesthetic for two reasons: to reduce the amount of pain, and also to control the bleeding as well. It helps vasoconstrict, helps narrow the blood vessels. And now we're putting in these clips so that we can flip the skin up. These are skin clips. We're going to flip them up in a second. I'll show you guys. And then what we do now is we can move the skin off the skull. You'll see that in a second. And now we move the skin up. Now we can see the skull. And now we have bone. So now we can start making our incisions. And I'll show you guys how that looks like in a second. And now we're going to make what we call the bone flap. So we use a very special type of drill called a stereotactic drill, which only drills into bone. As soon as it hits soft tissue, it stops. So now we've made our burr holes. We now want to make incisions between them. Okay, so we've made our burr holes, making sure there's no bleeding. Remember, bone also has blood supply, so it also bleeds. So you have to make sure the bone's not bleeding as well. And then we cut between. And then we now have a skull flap. So we can take the skull bit off. And then underneath that, we should see the area of bleeding. So now we can see the meninges, which covers the brain. And we're going to use some bone wax to make sure there's no bleeding. Stop the bleeding. And then we can cut into the meninges to see where the bleeding is. And now we can see the brain. We'll put some gauze there. We can then, after we've stopped the bleeding, we can then suture everything back together. And then we can use some saline to make sure there's no areas of bleeding. So there we're using saline. Good. We stopped the bleeding. And then we can reattach the skull, the bone, by using some screws and plates. Make sure it's okay. We stop any kind of bleeding. And then we can remove these clips and we can suture the skin back together. And that brings us to the end of that operation. So that's called an emergency craniotomy. Okay. So hopefully that was good. I would have loved to show you guys that in real life because it is very cool. But unfortunately the video got taken down. I think it was too gruesome. So let's go back to the screen. Let's have a look. Da, da, da. And perfect. So we have a lot of questions in Q&A. We can finish this off, then we can do some Q&A. So what is the name for a keyhole operation? By the way, tomorrow we can also cover some of the Q&A as well. Okay. Oh my God, there's 400 questions in here. That's mad. Okay, cool. Let me open the chat up again, by the way. You guys can chat. Perfect. Well done. So laparoscopic surgery. By the way, the bone drilling, like that actually sounds like a drill. Like it's literally like a really loud noise. It's a proper drill. And there's saws as well. It's very fascinating. There's so many different instruments. What are the common symptoms of appendicitis? By the way, these are kind of trick questions. Usually in medicine, if there's an option for all of the above, then usually it's all of the above. That's just like a thing for medical questions. Not always 100%, but more likely. What is the approximate location of the appendix? So this one, there's no all of the above. What's the location? Lower right abdomen. Well done, everyone. Good job. Come on. We'll try and finish on time today, but I think there's loads of questions. Right. What is the most commonly done test to identify appendicitis? CT scan. Well done. That's correct. What is the most common cause of an extradural hematoma, which is what we saw there? A blow to the head, a stroke, a brain tumor, or an aneurysm? What is the most common? So usually by some kind of trauma. Good. Come on, last couple of questions now. Which of the following is a potential complication of untreated extradural hematoma? So this one, there's that trick there, remember? All of the above. Excellent. Well done. What is the approximate mortality rate for untreated extradural hematomas? So we haven't covered this, but it's I mean, you can imagine if you don't treat it, then what do you think will happen? It's more than 30%. Yes, it's very high. Excellent. And last question for today. Come on. Which of the following is a potential risk for surgery? Pain, bleeding, infection, or all of the above? All of the above. Excellent. Well done. So let's have a look at the leadership board now. If you've made it to the top 10, then I'm so proud of you. You guys are amazing. The Hustler. I don't know who the Hustler is, but you got number one. Where's Pingu? Pingu's gone off. We've lost Pingu, but and Beyonce's fallen off as well. Shoot. Well done, the Hustler. Okay, cool. Let's go into Q&A now. So let's have a look at the Q&A. We have 2 minutes. So I think we'll do let me try and answer some of these questions. And then tomorrow there's another session. So you guys can log into that and hopefully Dr. Muzzy can solve some of those questions for you guys. A lot of the questions are about the lag. So I'm really sorry about the lag. I think it was just so many people were in the chat. It was I didn't anticipate that. So let's have a look. A lot of the questions are about lagging. Mute chat, please. Okay, that's another question. I actually can't see stop the chat, remove the blood. I think some people are using the Q&A to answer some of the questions, which is fine. Anonymous is asking, how long does it take to become a surgeon? So that's a good question. So it depends in which country. In the UK, it takes a few years after medical school. So you finish medical school, which is 5 to 6 years. Then you do 2 years of foundation training, and then another maybe 8 years of surgical training to become a surgeon. It depends what kind of surgeon. Neurosurgeons, the ones that operate on the brain, it takes a bit longer. Whereas if you want to be a general surgeon, so operating on the abdomen, it might be a bit shorter. So it depends what kind of surgeon. The longest surgeon are head and neck surgeons, maxillofacial surgeons. They take, because they have to do a medical degree and also a dental degree. So that takes a very long period of time. One of my friends is training to be a maxillofacial surgeon. So they deal with operations of the head and neck and very complex reconstructions. So that was one question. Let's have a look at any other questions. There are actually so many. What is the name of the app? So the app for anatomy was called Complete Anatomy, and the app for surgery is called Touch Surgery. They're both very nice apps. I highly recommend using them when you're studying for medical school. Maisie's asking, are all bleeds in the brain a stroke? If not, then what is the difference? Can all bleeds be saved if caught early on enough? So very good question. So no. So a stroke is when you have a lack of blood supply to the brain. Now that could be caused by bleeding, or it could also be caused by a blood clot. The more common type of stroke is actually caused by a blood clot. So you actually have a lack of blood supply rather than bleeding. And potentially, if you're able to diagnose a stroke early enough, you can save a portion of the brain, but there's always going to be some part of the brain that's slightly affected. Okay, so but they say brain is time. So the longer you wait to do anything, the more risk you damage the brain, and it's very difficult to recover the brain once it's damaged. Okay, but a very good question. Thank you, Maisie. Jelena is asking, what did you decide to go into your specialty? So a very good question. I actually liked a lot of things when I was in medical school, but I initially thought I wanted to be a surgeon, and then I did a few months of surgery, and I thought maybe it's not quite for me. So then I went into radiology, which is because I thought you need to know everything, and I really liked that. And then I did radiology, and then I switched to pharma medicine because the lifestyle was much more appealing. And that's what I'm doing right now. So there is scope for you to change specialties once you become a doctor, which is really good. And it depends on your life, like what you want to get out of it. But surgery is very fascinating. I'm always very fascinated by all my colleagues that do surgery. Let's have a look at any other questions. Okay, why do you type in the chat? I think the Q&A is completely falsified. There's too many muted there. So let's have a look at the chat maybe. Okay, the chat is also moving too quick. Someone asked about GCSE results. So with regard to exams, if you get a good result, that's really good. If you get a bad result, don't worry. There's always chances of still getting into university. But I would say you want to maximize your scores as much as possible if you can. Now, the reason being is because the higher your score is, the more options you have to apply to different medical schools. So that's why. And the best way, by the way, to study for exams, the number one way is to do practice papers. That's really the gold standard way. Like you can revise as much as you want. You can learn all the textbooks, but if you don't know how to do the practice papers and write the practice answers, then there's no good. I remember one of my friends at school was really smart, very intelligent, and he used to read all these encyclopedias. But then in the exams, he didn't have the exam technique and he wouldn't score very well. So exams are really about exam technique. It's you need to know how to answer the question. And the only way to know that is by doing practice papers. So if you can do as many practice papers as you can, then that's the best way to pass all your exams. This applies for GCSE, for A levels, for medical school exams, for all exams. It's all about exam technique. You can know everything in the world and still score very badly if you don't know exam technique. So just make sure you do that. Let's have a look. Any other questions? Okay. Lag, you're glitching. Log. Can the CT scan be for every part or only just for the abdomen? No, you can do CT scan for every part of the body. So that's what's nice about CT scans. Someone was asking why is the right bigger? So the right lung is made of three lobes, whereas the left lung is made of two lobes. The reason why it's slightly bigger is because your heart sits on the left-hand side. Anonymous is asking, I have school tomorrow and the webinar happens while I'm in school. So don't worry, the webinars are recorded, so you'll have access to this. And I think there's a certificate for this as well. I think it comes out in a month's time. So this will be able, you guys can access this. Um, let's have a look. Any more questions? What does removing the appendix cause? So long-term data shows that people who have their appendix removed, they can live a completely normal life. So that's why we think maybe the appendix isn't that useful as an organ, but there's different theories now. The appendix is thought to regulate the gut microbiome, which is really useful. So there's different theories, but in general, if you have your appendix removed, you can just live a completely normal life. Can we see the picture of the baby born with intestines outside of the body? Okay. Do you guys want to see this? Maybe we end on this. Okay, so I can show you guys. If you guys want to see it, it's quite gruesome, so I warn you in advance. Okay, come on, let's see it. Okay, so I'm gonna stop sharing my screen. So this condition is called gastrochesis. And I'm going to show you guys. Okay, so if you guys don't want to see this, please look away now because I'm about to show it on your screen. Are you guys ready? So this condition is called gastrochesis. Okay, so this poor baby is born with the intestines outside of the body. So because remember in embryology, when the body is being formed, your intestines come outside of your body and then go back inside. But there's an error in signaling, and that's why this has happened here. So this poor baby has their intestines hanging out. But what happens is the issue with this is that a lot of water can evaporate. So they lose a lot of water, they get really dehydrated. So these babies have to be fed a lot of water and they're given arterial lines to do that. And then what we do is we do an operation to put the intestines back in. Okay, and this operation is done by a pediatric surgeon. Cool. So that was that. Let's go back to this. Was that okay? Cool. All right, guys. So I think we can end the chat here. I hope you guys found today's session useful. There's a session tomorrow, which we carried out by Dr. Muzzy. I think it's about ethics. So I hope you guys find that enjoyable and useful. It was very nice to meet you all. And if you guys have any further questions after today's sessions, you can feel free to contact me. I'll be more than happy to help you guys. But yeah, I hope you guys found it useful. I'm sorry about the lag. I didn't know it was going to be so many people tuning in. But you guys were awesome. Well done, everyone. And yeah, I hope you guys have a great Saturday. Ciao, everyone.